So good morning and welcome to Your Voice, Your Story 2023. We are recording today's session for the benefit of people that might not be able to attend this morning, and for anyone that might want to look back on the stories that are being shared today. So we run this event as part of celebrating and acknowledging International Clinical Trials Day, which is actually tomorrow, but we thought we'd have a better chance of bringing everyone together on a Friday morning as opposed to a Saturday morning. I would like to begin by acknowledging the traditional custodians of the land on which we gather and meet today and pay my respects to their elders, past and present, and I extend that respect to the Aboriginal and Torres Strait Islander peoples here today. So Your Voice, Your Story is in its third year running, and it's with great thanks to our sponsor, Beringer Ingelheim, and of course to all the fabulous presenters who very graciously and generously give up their time to share their personal views and stories on what clinical trials mean to them. For anyone joining us today that might be new to the White Coats Foundation, just very briefly, we are a not-for-profit charity that was established in recognition of the need to raise awareness about the role of clinical trials in advancing medical science and healthcare, and particularly as this relates to patients and patient care. Our efforts aim to communicate with not only patients and carers, but the general public and also healthcare professionals, because we know there are knowledge gaps that exist within each of these communities. So Your Voice, Your Story is just one example of the many different initiatives that we run that aim to help raise awareness of clinical trials. There are actually 5 arms to the foundation that align with our charitable purpose, and this includes a research arm, an education and resources arm, a fundraising arm, a merchandise arm, and an events arm. And you're more than welcome to check out our website if you want to learn more about the work that we do, or reach out to any one of us at White Coats if you'd like to learn more. But this event this morning is actually quite special to us, because we think that the personal stories that are shared in the session today, we hope might give someone else a voice to ask about clinical trials or to learn more about clinical trials and as they may relate to their own healthcare journey. And of course, through the experiences shared today, we learn about what are we doing right as a sector and what could we be doing better, what needs to change. I think it's so important that we continually think about innovating the way we innovate the development of new treatments. So for clinical trials, for some people may represent hope. For some people, the words clinical trials have a connotation of risk, and for some it might be both. But we know that clinical trials have and do save lives. And with Your Voice, Your Story, we know that putting those thoughts and feelings or emotions into words can be difficult. So with Your Voice, Your Story, a picture can tell 1,000 words. And our hope is that with the personal images submitted via this event, that we are putting humanity back into the heart of the conversation of what we're talking about. Because ultimately the drugs and the treatments that are under development in clinical trials are really for the benefit of patients that might need them one day. And I don't know if anyone here is familiar with Ben Bravery. He wrote the book, The Patient Doctor. As he says, each of us will interact with the healthcare system at some point in our lives, and some of us to greater and lesser degrees, and obviously that will affect our experience. But it's for this reason that I think it's so important that we have a healthcare system that is inclusive and that is empowering and informing patients with all the options that might be available to them when and if they need to access them. So we have, as I said earlier, a really wonderful lineup of speakers joining us this morning. Very grateful to have each of them on board. So we've got Caitlin Delaney, Sarah McGorham, Natalie Merida, and I will be introducing them in more detail as I come to each of them in speaking turn. But right now, I just want to quickly acknowledge my colleague and co-founder, Fiona Cameron, who will be doing all things behind the scenes today to ensure our webinar runs smoothly. I just want to make a note that if anyone's got any comments that they want to make during the course of the discussion this morning, please feel free to pop them into the chat. If you do have any specific questions that you'd like to ask our presenters or panelists, please pop them into the Q&A, and Fiona will do her best to pick up on those questions and bring them into the conversation this morning. If we don't get round to answering any of your questions, we will do our best to get back to you after the webinar. I would also like to extend a really warm welcome to my co-facilitator this morning, Elizabeth Wilson, who is the Director of Strategic Site Relationships, ANZ Patient Networks for IQVIA. And some of you, if you joined us last year, may be familiar with Liz. She co-facilitated the event last year, but a lot's changed for Liz, since we last convened for this event in that year. And I'm going to let Liz talk further to that and allow her to introduce herself. So Liz, on that note, I think I might pass over to you.
Thank you. Welcome everybody. I'm very pleased to be a co-facilitator for this. I think it's very important. I work in clinical trials. I work for what we call a contract research organisation. So what we do is we are sponsors with a drug that they want to develop come to us, and we conduct the trial, work with the hospitals, work with the investigators. So my life is running and conducting clinical trials. But my background is that I was a hospital pharmacist specialised in cancer. So I'm very conscious every day of the work I do, and being removed a little bit in the company I work from the actual patient. I do think every single day that the reason we do what we do is to support and help a patient. There's a patient at the end of every decision we make. But it was the reason I've put, and I'm not entering the competition, but I put this forward because, well, first in 2018, I was diagnosed with a stage 1 renal cell carcinoma. So there was no need for a clinical trial. It was an open surgical removal. But then off I went, and then in December of last year, I got diagnosed with stage 1 vulval cancer. And again, because of the position of the tumour, I had to go through 30 treatments of radiation. And I hadn't had a lot to do with radiation, but I work in clinical trials every day. Now, the therapy I had is standard of care. It's exactly what you do for my tumour. But I became the patient very quickly, and all my knowledge goes out the door, and I become this sort of person that goes, well, I should know about this, I should know this. But you lose, I think, a lot of that when you become the patient. And I have to say that the staff that were around me and supported me were incredible. They did treat me as a patient and someone that I felt important. I felt that they were taking care of me. But the radiation treatment, as I said, only came to be standard of care because of the work of clinical trials. So any medicine you take, any device you're using that is now on the market and you're taking it for whatever medical condition, had to go through a clinical trial program to get to where it is. Because in medicine, we work on evidence. Evidence-based is everything. So it's very, very important. And anyone who is involved in a clinical trial, that is the way we get new medications so that patients can improve their lives. So I'm very humbled to be here, and I look forward to the speeches or the talks from the patients that have put their photos forward, and thanks in advance of I think what are going to be great stories that we're going to hear.
Yeah, thank you so much, Elizabeth. And your story really aligns with one of our earlier initiatives called the Thank You video, which was one of the first things we launched as the White Coats Foundation. And in that video, we actually talk about if you have ever taken a prescription medication, then you have a clinical trial or a clinical trial volunteer to thank. And I often ask that questions when I do presentations. I ask people, have you ever taken a prescription medication? And 100% of hands will go up in the room, and then I say, well, you have a clinical trial volunteer to thank, and then people just kind of go, yeah, I actually never really thought about it that way. And it applies to even treatments that we probably take for granted, things like antibiotics or painkillers that we may regularly or not regularly rely on, but occasionally need. So yeah, thank you for sharing your story with us. So I think that we might cross over now to Caitlin Delaney. So Caitlin is a patient. She's a compassionate care advocate. She's also the founder and managing director of Carefully, which is dedicated to changing care culture and helping, I suppose, healthcare professionals provide more compassionate care. And Caitlin, in addition to learning more about what clinical trials mean to you, I hope that might be some time to also learn more about the work that that you do, the amazing work you do with Carefully and how that came to be. So Caitlin, welcome and thank you for being here with us today.
Yeah, and I just want to thank everyone for having me here today. I'm really thrilled to be involved. I just want to firstly say I do have to leave at 11:30 sharp, so my apologies if I have to leave when other people are talking. I have a puppy in the background who's barking. Bit heads up. So yeah, I've got a science background myself. I worked in embryology for over 20 years. I set up, established and managed IVF and sperm donor clinics in Europe and Australia. So I have a healthcare professional background. So kind of like yourself, Elizabeth. So I knew coming into my full-time other role as a patient that it was really important. Science is really important, and that's how we get advances. But I guess I didn't really realize how disempowering and vulnerable patients can be. And as Dr. Ben Bravery says, we're all going to interact with the healthcare system at some point. But when you're a cancer patient and an advanced cancer patient, it is pretty much a full-time job. Any chronic illness will be like that. A lot of patients I've noticed slip through the cracks. They're not aware of clinical trials or certain treatments that you perhaps advocate and get off-label drugs. So because of that, and because of my healthcare background, and because I've had a really great experience as a cancer patient in a hospital where I've received compassionate care, which has made a huge difference, I started my own business, Carefully, as Christine said. So in Carefully, we're a mixture of psychologists, scientists, education experts, facilitators, actors, and we train healthcare professionals and others how to sustain and cultivate that compassion that we all have that can be hard sometimes in challenging circumstances. Because that impact, I guess, and that sort of links into the clinical trials as well, of that compassionate care. Sometimes it's compassionate access, sometimes it's just really good communication. Sometimes it's just seeing the patient as the human, not the diagnosis. The impact of that compassionate care and lack thereof is huge. And I won't get too much into that, but I also lost my mother-in-law in very tragic medical circumstances because of just a very poor communication. I think on a number of things. So they're the real reasons, my experience and her experience, why I started my business. But to go more onto my experience rather than journey. So I was diagnosed in 2017 with stage 4 clear cell ovarian cancer. So ovarian cancer is often diagnosed in late stages. It's very hard to, I was only 39, so no one's really looking for cancer at that age. I have no obvious cancer in my family. So my daughters were still in nappies. I think they were 18 months and 3 when I got sick, 2 and 4 when I was diagnosed. And yeah, I mean, needless to say, that was a pretty horrific time. But over those 6 years, I've learned a lot. And I guess the biggest message, or learning, I should say, I've taken away is that one has to really self-advocate to be able to get the treatments or access the treatments they need. So part of my Carefully business as well is or a big part of it is the patient advocacy and advocating for patients that don't have a voice, who can't speak up. I feel a responsibility to speak for all patients. So when I advocate, it's not just about ovarian cancer, it's not just about rare cancers, it's not just about cancer. I advocate for all patients. But of course, my experience is predominantly with cancer. So I was very fortunate that I was NED for 2.5 years with standard treatment. But because I have a very rare pathology, it's very hard for me to access drugs. So that bench to bedside time is I think ridiculous. And so my takeaway, I guess, for today that I want everyone to think about, there's 4 things in terms of trials. Yes, they're wonderful, they save lives, they give lots of hope, but getting to them is sometimes tricky. So sometimes visibility, even knowing that they exist, because I feel like it's really only a doctor that tells you about clinical trials, and it's about who they have a relationship with from pharma, from hospitals that they might have a good relationship with. If that hospital has a really good clinical trials team, and so on. I also, unfortunately, in my and many other people's experience, that oncologist or doctor is a gatekeeper for information, and they sometimes do. So I am a public patient, so I think often people assume that I won't be able to afford off-label drugs or be able to afford things. So often things aren't even mentioned to me, or clinical trials that are overseas or in different states aren't mentioned. Whereas I feel that all options should be given to patients, empower them, give them as much information, and then we make the decision. So we decide, do I want to travel to Melbourne? Would I travel to America? And so on. So the visibility is a big one, because I have only really come across clinical trials in the last couple of years, and I've been diagnosed 6 years ago. Accessibility is huge as well, and that's really what my story was about. I'm not going to read out the story because you can always just read that online, but I celebrate everyone, you know, when they get drugs listed in PBS, or you know, there's clinical trials and people are able to, they're eligible for it. I always celebrate other people's success and fortune, but I do get immensely frustrated when I see time and time again, say ovarian cancer or other rare cancers are excluded, or even when ovarian cancer is included, it's only high-grade serous pathology. It's not my clear cell pathology. And I find that frustrating from a number of ways, because I have been my own clinical trial, and when I recurred in 2020, I'm being confused about timeline, 2020, everyone assumed chemo would work again. So they put me onto a clinical trial. This is the only clinical trial I've been on. And this photo is me waiting to hear about this clinical trial. So you can see I'm looking a few years younger there. My husband and I were waiting. It was a different hospital. I'm not used to that hospital. The hospital I'm treated at in Sydney, normally it feels like a private hospital, even though I'm public. I'm very fortunate. It's very new. It's very beautiful, lots of light, vertical garden, lovely holistic care. I went to a different hospital, which felt very, very public, so very, very different. Different doctor that I had no relationship or rapport with. I had to travel further to get there. And I wasn't really aware what this drug was going to do, but I knew that I was the last person in Australia of 8 to get on it. And I felt like there was a bit of pressure to get on that trial. I felt like I really wanted to get number 8. And I, you know, as a scientist, I, you know, felt that I was informed, and I certainly didn't feel that I didn't have a choice in that. But unfortunately, that wasn't a great experience for me, but that hasn't turned me off clinical trials. I still think clinical trials are amazing. And what was good about that experience is the doctors were very quick to get me off that trial when they realized it wasn't working for me. And they said, go on your chemotherapy. And unfortunately, that chemotherapy actually didn't work. So I became resistant to chemotherapy straight away. So having that clinical trial, my disease had progressed a bit, and then I had chemo, and no one checked me for 3 months. So I probably had 6 months of cancer growing before I actually got on a treatment that actually did anything. At that point, I contacted an expert in Singapore for my pathology, and he suggested a clinical trial with 2 drugs. However, there was nothing else. I did it in 6 months. I've got a young family. Time is not on my side. So that is, I guess, something I wanted to flag as well, is that timing of trials. They can be fantastic when it's at the right time in the right place. But it can be very difficult to get on it, not just because of your pathology or sort of rare disease, but also if it's actually open and recruiting at the time you need it. So there's a lot of things that have to come into play. But I knew that this drug combination, which had worked in endometrial cancer, the data had been extrapolated. This doctor said, I know that your clear cell pathology is similar to endometrial cancer, and I think it's going to work. And I said, what would you do? He said, it's going to be $12,000 a month off trial. And I said, I'm going to do it. So that is financially crippling. And And so, you know, I'm married to an actor, I've got a young family, I'm a public patient. So I went to my oncologist here in Sydney and I said, this is what I want, even though I know it's going to cost an arm and a leg. And we just accessed my life insurance to be able to pay for that. So I appreciate that those drugs are around because of a clinical trial and a different cancer. And that's another point I want to make. I feel like we need to fast track that bench to bedside process with trials. I know we're moving more towards tumor agnostic bucket. Is it bucket trials they call it? Yeah.
Umbrella trials, bucket trials, basket trials. Yes.
Yeah.
And cancer.
You know, a different pathology in ovarian cancer to then be shown. And then my little down the bottom of the ladder, one that no one really cares about so much because there's so few of us to wait for that. I don't have 1, 2, 5, 10 years. So I think that's where my frustration around, there's so much hope and there's wonderful drugs out there that are coming to trial, but we can't always access them and we can't always access them at the right time. So that visibility, accessibility, and the efficiency. So that's coming back to that, you know, how long they're taking to get from phase 1 to phase 3 to be funded. And I feel like, you know, there's a model in the UK where they have a pool of money for drugs that patients want to access that aren't yet funded, that I think, you know, for a couple of months and it's working, and they'll give it to you for compassionate. So I'm really trying to advocate and work with people with the government of how we can try and get that to happen here. And I think that clinical trials are tied up with genomics as well. And I know I'm running out of time, but I think you can't really separate the two. And the reason I'm still here, and it's far outlived my prognosis, and I'm not going anywhere anytime soon, is because I'm health literate, I'm a scientist, I've self-advocated, I've got second, third, fourth opinions. I've been able to access drugs off label that have been shown to work in trials for other more common cancers. Yeah, and I've been willing to put that risk, you know, that's my decision to make, to say, I want to take these drugs. But to be penalized financially, or to not get access to a trial that could really work for your cancer disease, I feel is immoral and hugely unethical. And I understand that hasn't got an endless, infinite amount of funding, but I do think we can do a lot better. And I think we need a big paradigm shift. We need to change this, the way that we inform and educate people about clinical trials, the way that we inform and educate the oncologists about clinical trials, or the other people that can us, because if that doctor doesn't work, they did tell us about 1 or 2. Yeah, so that's I guess my experience. But you know, they can radically transform lives and save lives. I know that, and I'm actually now waiting. I'm on the waiting list for 2 clinical trials, so I'm on a chemo break. I progressed for 7.5 years. So I have progressed with disease in my a lot of in my lung. So we're now just giving me a break from chemo, and I'm on 2 clinical trials waiting list. I just want to add one last thing before I wrap up. The reason I'm on those waiting list trials is because I had genetic testing that normally is not common for ovarian cancer. Yeah. Yeah. No one is routine for ovarian cancer, and I came back positive, and I'm now eligible for drugs that are used for breast cancer patients with amazing results. So that genomics is tied up. You know, not everyone's offered it, not everyone gets it funded, and not everyone certainly gets it in a timely manner. Patients don't understand the difference between germline to our blood and our somatic tumor testing. It's very confusing, and as I said, I just breaks my heart seeing people slip through the cracks. But this is wonderful, because I think having a really good dialogue about it and bringing people together from different industries, brainstorming what we can do to change it is really powerful. So thank you.
Thank you so much, Caitlin. There's so much to unpack, and you know, in what you just said there, we could talk to you solely just for an hour.
I think, go on.
Opening statement, I did say that these stories are important because we need to understand what's working and what's not working and what we can do better. And you talked about access and eligibility, and I totally agree with you that that's an area we need to improve. But you also said in your story that you sought expert advice from someone in Singapore. What led you to go to Singapore for information about clinical trials? I'm curious, were you not getting the support or the information that you needed from your oncologist here?
Look, it wasn't that I went specifically to him for clinical trials. So when the chemotherapy didn't work and I was carboplatinum resistant, which obviously great, with my first occurrence to be out of treatment options pretty quickly. And I went to, I've always I kind of interview different oncologists and scientists whenever I progress. So I kind of do like 4 or 5 different things where I reach out and try and work out what the next thing is, because even as a scientist, I can't read and digest those papers. And I'm also, when you're at the center of the storm and that trauma, you can't digest it. And you're looking at progression-free survival stats for 2-3 months and thinking about my children and will I see them get to high school? Will I see them get to double digits? Will I even see them start school? So I need to outsource that. And then I saw the best person in Australia pretty much for a second opinion. And he really didn't give me much hope. He just said, we don't know. We're in uncharted water territory now. We don't know what's going to work.
Right.
Very tough, isn't it? I know the thing that you were talking about, your pathology being a rare pathology. This is the way that cancer and a lot of different, not just cancers, but diseases are moving. Years ago, or say in the last sort of 15 years, we used to have a lung cancer trial and it was all comers. And so you'd have, lots and lots of patients for that particular trial. But as you talked about, now they're doing genomics and biomarker testing. And for example, with lung cancer, it's now 19 different types of lung cancer, for example. So you're exactly right. Now we're actually getting more and more into clinical trials that are rarer and rarer to find patients, because we're funneling down into sort of into these subtypes. And there's we are. I had a conversation last week with actually one of the research nurses at the MCRI, which is at the Murdoch Research Unit in Melbourne, and we were talking about children's cancer trials in rare diseases and ultra rare diseases, and how do we bring those trials to Australia so that every child has an opportunity when they're diagnosed with that genetic disease or whatever they're diagnosed with, has an opportunity. And I think we've got a long way to go, but we have to have that conversation. And one other thing I was going to mention too was what is the federal government have given about $175 million to the different states, and this is talking about access and equity for what we call teletrials. So what they're trying to do is set up the trial portfolio so that you have your main sort of key opinion leader site, if you like, and usually there'll be a metro site, but then there's a network of regional sites so that patients who live remotely or regionally are starting to be able to get the same sort of access. And I think this is crucial for us to do this so that, one, as you said, you're a mother, you've got young children, that you have access to a trial, but if you don't live near that hospital that's running the trial, you still have an opportunity to be involved. So I think we're going in the right direction. I think you're right, we do need to hasten what we do. The old traditional phase 1, phase 2, phase 3 trials, we are starting to look at how can we get those drugs to market much more efficiently, because time is a patient's life. And the last thing I was going to, a couple of last things, you talked about, when you're a patient, and some doctors are different. There was a really good movie, it's very old, it was William Hurt years ago, and he was a doctor and became a patient. He got sick, and once he'd been treated, he absolutely changed the way he taught all his residents that came through. He made all of them give themselves enemas and do all the things that, sometimes they don't think what it means as a patient. Like, this isn't as easy as you think. So I think that's important. And I think, 5% of patients get access to a clinical trial at the moment. We've got a long way to go. And I think I was on conversation with one of our colleagues from Europe and sort of saying, don't forget Australia, we have patients, we need access just as much as the rest of the globe. So your story was so spot on. Thank you for sharing it with us.
Two quick things, I know we're going to move on, but on that too, the N=1, like I am.
You're an N=1.
Yeah.
Around the world with this guy in Singapore. So, you know, everyone just can't believe it because no one else is yet on that conveyor with my cancer, but it's worked and it's kept me stable for 2.5 years and no one can quite believe that. But where's that data going? Who's got that data? And it's still meaningful. And that's why I think we need a living evidence model, because it can't just be, I am that living proof. You never, with a rare disease, going to have enough data. You just never, to be evidence-based. So we actually need to change the way we think about that. But anyway, I'll wrap up there because I know that.
No, thank you so much.
So right, so true. The N=1 and how do we still treat those patients? I think it's so important. And you're right, thinking that it worked in this tumour, maybe it'll work in this tumour. I think that those opportunities are so important, so important.
Thank you so much, Caitlin and Liz. I've got a heap more questions, but we do have to move on in the interest of time. So I'm going to now introduce you to Sarah McGorham, who's a wife, mum, and GIST and rare cancer advocate. And I'd also like to point out that Sarah was actually recently awarded a Medal of the Order of Australia for her service to community health. And I think that that's an incredible achievement, and it speaks volumes to her commitment to improving healthcare and access to better treatments for patients and their families. So congratulations, Sarah, and thank you so much for joining us this morning to talk to us about what clinical trials mean to you.
Thank you so much, and thanks also Liz and Caitlin for sharing your contributions as well. There's so much that's relatable from Caitlin's story, and in particular I am also a rare cancer patient, so I endorse everything that you've just said. It's challenging, it's different, and the clinical trials without a doubt have that sense of hope, as well as the complexities of the process as well. So yeah, thanks Caitlin, that was great. So I guess to start with, I thought I'd just focus on the photo that I've shared there, which is, I think, captures a moment in time with my dancer. Within this photo, it's a picture of me getting treatment. I'm sitting in hospital, which I've done for hundreds and hundreds of hours over the years, but which I can guarantee is not always the case. But in that particular moment, we recently had news that the treatment that I was on was effective and was working. So the anxiety then reduces when you're in hospital getting the treatment, knowing that it's making you feel a little bit rubbish, but doing all the right things. So then across on the other side is my mum, who flew in because I was going through a rough patch with my treatment. And the photo was taken by my husband, and then in the son George. So he, at the age is 5 years old, and my mum had just picked him up from preschool, and he wanted to come in and see me. And I think my husband and mum were doing a handover with George, and that usual juggle of trying to live with the disease, manage the treatment, but try and be present as a mum. And Tom was there juggling his work. And so, yeah, life is really difficult and complex, but you just manage with what you do, and in whatever way you can. And what I love in this photo is there's George with his pencil and paper and just comfortable, casual, and this is his normal. This has been his life. And he's just drawing a picture. And I also just noticed as we were sitting here that on my mum's lap is the packaging for a packet of pencils, which I'm sure we spent hundreds of dollars in a hospital gift shop just restocking things to entertain the young one. So yeah, this is definitely a moment in time, and as we've already heard, that sense of time, I think, is a critical element to clinical trials. So for my story in general, it's 1996, I just turned 18. I just started uni and I was diagnosed with a rare cancer called gastrointestinal stromal tumours. It was rare. I didn't know of anyone else in Australia that had the disease. I think I'm in Canberra. It was the first person in Canberra to be diagnosed with that. Research had come out about 6 months prior that informed us that GIST did not respond to chemotherapy and radiation. So that was a very, very positive finding before my diagnosis. But the flip side of that is that they were yet to find a treatment. So I had over 50 seedings of tumours in my small bowel and no treatment, no cure, prognosis of about 12 months, and was just encouraged to get on with life as best I could, and with the sense that let's hope that the speed of medical research is on your side. And so at that point, my survival was dependent on the speed of all treatments and all research, which is definitely a powerless place to be when you think all I can do is just, be healthy and kind of focus on me, and everything is in the hands of the researchers, the pharmaceutical companies, the pace of approvals, the funding for trials, the access of trials, the eligibility of trials, completely powerless situation. 5 years after I was diagnosed, so they were managing with tumours growing. I would just go in for emergency surgery because the tumours would rupture blood vessels. And so life is a little bit of a knife edge. I'd like to say that's changed, but it hasn't. But that is definitely normal. But after 5 years, there was just with this targeted therapy called Gleevec. And that came out in 2001. I got a call from Sydney from a doctor saying, there's this new drug, you're eligible. And that was the very first time I'd heard of a clinical trial. My instinctive response to that was experimental, dangerous fear. I was, I think I just turned 21. I just didn't really know a huge amount about the medical system. So I went up and met with the trial nurse, and we had a number of hours of talking through the pros and cons and the risk and the benefit. And by the end of the meeting, it was absolutely clear it was a really positive option for me. So I commenced the trial, and the treatment stopped the progression of my disease. And with GIST, that's the way it works. There is nothing yet established that will stop that will cure our disease. It just stops the progression. So that was way back in 1996, and it was the treatment worked for a few years, and then I'm moved on to another trial, which was in 2011. And so this photo was in, I'm skipping forward. I'm now actually at 27 years since I was diagnosed. And across that time, I could bore you with endless highs and lows, but I'll stay focused on the clinical trial. But across that 27 years, I've had disease the entire time. Every treatment that I've had has been an emerging treatment, and some of them have been on clinical trial, others have not, because as Caitlin was saying, you kind of have to, there is this kind of stars have to align, planets align, to reach the eligibility at the right moment when your disease progresses. I've had moments when I've gone in for an MRI thinking, all right, there is a trial available. If it's going to progress, hopefully it's now and not 6 months' time when the intake closes. So that it's definitely a challenge. But the flip side of that is that, 2011, when I was on this trial, we were trying to get a third line therapy for GIST at the time. I think an important thing, a really important element for me with clinical trials is I had signed up for this trial in 2011 and accepted the challenges of increased appointments, increased pathology, increased imaging to meet the criteria of the trial. At the time, I just thought, this is important for the greater good of the disease, that this will help everyone with the disease. And what I wasn't expecting is that it had a really profoundly positive impact on me understanding my own health. So at that point, I then had 6 months of data of really clear, accurate, consistent pathology, and that my doctors were analysing as well as the trial nurse. And through that, we're able to identify that I had another condition but was having a significant impact on my health. And that was only established, understood because of the data and the increased understanding, thanks to the trial. So I then started getting parallel treatment to that, which has had a profoundly positive impact since that time. It was not long after that the phase 2 treatment was not bringing in the results that they were hoping. So the trial wound up before I was able to commence that treatment, which as a patient, I put a lot of hope in having that next line of therapy. So absolutely devastating. I think years have gone past since that point, and it was a really positive outcome for me, I guess, because all the other patients had gone through that. So it's on the back of other patients volunteering for the trial that then I benefited. I then, when my disease progressed, we then looked at an alternative emerging treatment. Now that alternative treatment I commenced in 2015, and that has stopped progression of my disease for the last 8 years. Had I jumped on the previous one that they were trialing, that would not have been the case. So the positive benefits for me as a patient being on this trial were clear. The broader benefits for the patients across Australia with GIST were really significant as well. I think from my perspective, it's just a really the ripple effect of the clinical trials are significant. I know for me within our family, and then just seeing patients coming through now who are starting treatments. They're being diagnosed and they've now got 3 lines of therapy, which 25 years ago when I was diagnosed, we had none. The data from all those trials have then been used to support presentations to PBAC to then get them listed on the PBS. So they're really significant as well. So I think, the data are incredibly beneficial. Caitlin's point as well, trying to get enough data for rare cancer patients is a major problem. So I think the research is wonderful. The system that data feeds into needs work, because at the moment it's nearly impossible for the rare cancer patients to meet the criteria. But from a patient research perspective, that's I'm incredibly grateful for the opportunities that the trials have offered me. And then also to touch on Caitlin's point about the genomics as well, my most recent trial I participated in is the St. Vincent's Garvan MOST trial, genome sequencing and matching the mutational analysis to target horizon. That is another little lifeline that I'm hanging on to. We're yet to try and find a match, but my current treatment is working. So again, those treatments are buying me time to live longer while the research evolves. So I am really mindful of the time that we have, but I think overall it's just the clinical trials. What do they mean to me? They gift me time, they buy me time, they give me access to emerging treatments. And that time translates into that little photo there, the young George who was in that photo. My first trial was before he was born, and he's now a 6 foot 16-year-old about to graduate from year 12 next year. So that time is a gift to all of us. And so, you know, thanks for inviting me to speak on Clinical Trial Day, because it really is one of the lifelines for rare cancer patients in particular.
And I think, Sarah, that's a really good point. And Caitlin said the same thing about rare diseases generally. And what we need to do more and ensure is that we maintain and have registries for all, you know, global registries for all of these various rare tumours. So as you said, the data, there's little data. So at least if we can, you know, have global registries and pool that data and get as much as we can. And the other thing that you talked about around, and so did Caitlin, around data that's important, is even if something doesn't work, and this is sometimes where I get frustrated if, as you said, a trial shut early because it wasn't working, even that information is vital to be written up. Negative data is just as important as the positive, because it helps us learning and where we go in the future. So thank you.
And repeating the same work
Yes.
over duplication of it, it's so unnecessary. It delays the whole process. Sarah, thank you so much. I think if I had to create a word cloud with the positives and the negatives of what I'm hearing from both yours and Caitlin's stories so far, in terms of the positives, I'm hearing that clinical trials are giving you sort of gift of time, hope, lifeline, family, options. But then when it comes to sort of the negative side, you know, it's about eligibility, access, and as much as they can give you time, it's all about timing as well, which is very critical. And, you know, gatekeepers, oncologists, you know, and access to trials, I think, you know, should be a right, not a privilege. And it shouldn't be happening randomly. It should be happening routinely. And I think, you know, we're starting to hear some really clear themes about what we need to change and what we can do better. And I'm very grateful for you sharing your experience, and Caitlin as well. I think on that note, we'll open it up for questions if we've got some time at the end, but I might move on to Natalie now and give her a chance to share her story. So Natalie is a NICU parent and co-creator of the NICU Lived Network. And we throw a lot of acronyms around in this industry. So just to clarify, NICU is Neonatal Intensive Care Unit, parent, but I'm sure Natalie will provide more information about that for us. Natalie, welcome, and thank you so much for being with us this morning and agreeing to share your story about what clinical trials mean to you with this fabulous photo that you've submitted.
Good morning, everybody, and thank you for the introduction. And thank you, Caitlin and Sarah, for your amazing stories. Yeah, I've learned a lot today, and they're truly inspiring. So thank you. So hi, everybody. My name is Natalie. I'm from the NICU Live Network, and NICU is Neonatal Intensive Care Unit, which is the unit that looks after premature and sick babies, essentially intensive care for babies. So this picture here that we have in front of us is of my twin boys, Rafi and Dante. And it describes what they're typically like. They're always together and always up to mischief. And today they are happy and healthy. But in 2014, they were premature at 28 weeks, 6 days at Royal Darwin Hospital. because they were so small and premature, they spent a long time in hospital. I think as newborns, they spent 105 days all up, which was a really long time for us. And during that time, they received a lot of procedures, treatments, and it was just a very intense and scary time. But the care they received was amazing. And although the boys weren't, when they were in NICU, they weren't actually become participants of a clinical trial. What I'm very mindful of the fact is a lot of the care that they received was informed by past clinical trials. And for me, that's really, really important, that my kids in that during this really scary and vulnerable part of their lives were able to receive amazing care because of all this work had been done beforehand, so that, you know, the doctors and the nurses knew the best possible things they could do to ensure that my kids had the best possible chance of survival. And you know, today they are healthy, happy, and wild, which is lovely. And I think for me, stepping back, the important thing about clinical trials is that they answer the really important questions that need to be answered so that it can potentially save lives. You know, and not just lives in Australia, but overseas as well. And that's really important for me. And the space of the specialty of neonatology isn't really that old. I mean, I think it's kind of modern neonatology was, you know, kind of formed around the 50s or 60s. But again, I'd have to double check that. So there are still, and you know, and the survival rate for premature babies in the NICU has improved dramatically in the last, you know, 20 to 30 years. Like, I don't know if my boys would have survived if they were born 30 years ago. So yeah, there's been a lot that has happened in that research space to, you know, to improve the outcomes for these babies, for premature babies. But there's still, because neonatology is still fairly a young specialty, I'd say, there's still a lot of questions to be asked. There's still a lot of uncertainties and a lot of unknowns. And that's why I think clinical trials going forward are so important, because there's still lots to do. And it really warms my heart, because I'm someone who's quite involved as a consumer advocate, as a parent representative in this kind of neonatal research space. And I get to hear a lot about these amazing clinical trials that are either you know, either being planned or underway. And it really warms my heart, because there's this relentless drive by health professionals to, you know, do this work so that, you know, at the end of the day, they have answers that can be used and applied to the care of babies and save, you know, thousands more babies. And I guess going back to my notes, I think what's really exciting to me as a parent who's had that lived experience in NICU is that health professionals in the clinical trial space and more broadly in the research space are really kind of receptive to getting families with lived experience involved in clinical trials. And I don't mean just in the participant as a participant, but also in just in the planning and designing and implementation of clinical trials as well, to make sure that clinical trials, you know, while providing important health, potentially providing important health outcomes, will also be done in a way that is relevant to NICU families, respectful and appropriate for families as well. And that's a really exciting space. And I know my colleague and friend Melinda Cruz has been who's a parent and researcher in the clinical trial and research space, has been working for years alongside NICU researchers in clinical trials, and it's really, really exciting to see a parent actively involved in designing and planning and implementing these with researchers. And so my hope is eventually that more and more families will become I see more and more families with lived NICU experience become interested in research and clinical trials and wanting to get involved. And, you know, my takeaway today is if you are someone with that lived experience and you've always thought about the research space, the clinical trial space, please strongly encourage you to get involved in some shape or way. I think there is amazing power in our experience as NICU families, and I think we can really, you know, contribute to making positive changes so that clinical trials are better, happen faster, are more accessible, are more equitable, so that, you know, our babies can benefit. More and more babies can benefit, not just here in Australia, but globally as well. So I think that's my little short talk for today. So
And
thanks,
Natalie,
guys.
thank you. I think what you said is really important, and we've got more and more patient advocacy groups and consumer engagement groups. And what we're trying to push is, you know, that protocol for the clinical trial, for example, that's written in a global office by, you know, a sponsor, actually doesn't think about what I term loosely as the end user. So the patient, what's the patient journey going to be like? How are these children going to be able to go through the trial? How's it going to affect the family? And having the consumers, they're sort of those groups, or yourselves, the parents, involved in that, saying, well, this won't work, this is a better way of writing it. So we need to continue having involvement of parents, patients, consumers, to make them, you know, user friendly.
Yes, exactly. And I was thinking about when I was listening to Caitlin and Sarah's discussion today about, you know, it was a real eye-opener for me in terms of the challenges they face with clinical trials. And thank you so much, guys. Like, I just, I was really quite moved by the talks. But when you were highlighting that issue or those challenges that you were facing, I was at the same time kind of thinking, is there a way through this kind of this consumer advocacy space that, you know, if we're involved at the beginning in the planning and the designing, that we can kind of address or frame research so that it can potentially kind of address those challenges that have already been raised by Sarah and Caitlin? Is there a way to kind of build it in from the beginning so that, it can perhaps shift that space?
That's a good point, Natalie, and I think there is an increasing movement towards involving patients with lived experience in that way when it comes to designing clinical trials, and even at the point of, you know, research prioritization, you know, the questions that you're looking to address in clinical trials. But one of the things that came to mind for me when you were speaking was that it's one thing to be making a decision about participating in a clinical trial for yourself, but then as a parent trial, that additional burden and responsibility that you feel making a decision on someone else's behalf, and whether that is as a parent for your child or as a carer for someone you love. I can only imagine that there's this extra layer of responsibility associated with that decision, given the other challenges, you know, that you're faced with in that moment.
Yeah, and to be honest, because we've never been asked that question whether we want to participate in a clinical trial, but I think if we had been, I think it would be challenging, because I think at that time I would have had assumptions about, like Sarah was saying, you know, clinical trial connotations of experimental or risky. So I think in this consumer advocacy space, that's what a lot of what me, Em and Mel are trying to do through a NICU Lived network, is just kind of talk to people more about clinical trials and kind of, just kind of address some of the kind of myths or fears or unknowns that families may have about what clinical trials are in the NICU space, what it could mean to them. So that when somebody does get that question, perhaps it's not such a scary or a kind of daunting decision after all.
Yeah. No, thank you. Thank you so much, Natalie. We've only got a minute left, and I just want to ask one more question to our presenters before we sort of wrap up. And if anyone's got a question from the audience, please feel free to pop it in the Q&A. But one of the things that's really stood out to me in the discussion this morning is, you know, that the doctors are the gatekeepers of the information that could potentially change people's lives. And I think when you're a patient, you have this high expectation that you're going to get the information you need from your healthcare professional, your treating clinician and team. I just want to know from your perspective, and anyone can answer this, do you feel that your expectations from your treating healthcare professionals were initially met?
Yeah, can just briefly speak to that, is that there seems to be a specialist that is plugged into the network, then I think you've expectations can be met. But if you've got a more generalist specialist who isn't informed, then just through my advocacy, last year I think I received, I think, probably 12 messages from people around Australia who thought they were at the end of life, end of the line of treatment, and half of them were eligible for clinical trials that they didn't know about. So their expectations definitely weren't being met by their specialists. And through the patient network, they were then enlisted in clinical trials. So definitely an area of challenge.
Yeah, and look, and I think it's a matter of access again, and access to information for both patient and clinician. And I think there's difficulty for both healthcare professionals and patients in getting access to the right information at the right time. You don't know what you don't know. And so, yeah, I think that's definitely something that we're hearing, that, you know, in an area we need to improve. Access to the information and education about how clinical trials can play a role in the management of patient care. Yeah.
I was going to say on that, Christine, it's also about having, you know, and we spoke about this recently, having a reliable, collaborative, transparent clinical trial platform. I know there's some great stuff around, and I really do, the challenges that come with that. But, you know, being able to do a search term by your marker or mutation rather than your tumor stream, because a lot of the time that's what you're looking for. And I feel like doctors often make assumptions about not just what you can afford, but what risk you're willing to take. They make those risk decisions, assessments for you. They'll be like, oh, but this is evidence-based. But some of these evidence-based might have been being done for 30 years. And the results haven't changed for 30 years for ovarian cancer. So when you're looking at, well, I want to think outside the box and I want to take risk, what's my risk profile like? Like, what am I willing to do? That's up to me to decide, not my doctor. But to be honest, I just think that doctors are unaware of everything that's around there, and they do to point you towards things that are more evidence-based and safe first. Whereas if I had done that, I wouldn't be here. You know, I very much doubt I wouldn't be here. I would have been back on another chemo that probably wouldn't have worked, and I would be very unwell. And I've just seen my daughter turn 10. I didn't even reach primary school. So I think there's that education piece, but also that stopping those assumptions about patients. You know, I had very early on doctors say to me, oh, but you wouldn't want to, don't ever travel overseas for treatment. Like you don't want to do that to your family and husband. I thought that was a really interesting, from not just one doctor, quite a few from my team. And I thought, well, that's interesting, because am I bad if I want to do that? My husband and family, like your health is, we'll do whatever it takes for you to be here.
Yeah, that's right. It's your choice, and you just need to have access to all the options. And I think Janelle in the chat's also pointed out that we all have different risk profiles, and clinicians need to present all the options so that you can ultimately make that decision about what's right for you and your family. It's access to choice, and that's what we're continually advocating. Yeah. Thank you so much, Caitlin.
I'm going to have to go because I have to go and catch up.
Yep.
Really lovely involved. Thank you so much, and hear all your wonderful stories, Sarah, Natalie, and Elizabeth. It's just fantastic. So thank you for doing this, because I think it's really, really important. And I'm so sorry. Have a great weekend, everyone.
Thank you, Caitlin.
And thank you to everyone
travels.
for sharing your such personal aspects of your journey with everyone today. I think that looking at the comments in the chat, that everyone's taken a lot from what you've said today, and we very much appreciate your time. Elizabeth, I'll let you, if you've got any final words before we.
No, I think the stories are empowering and the conversations need to keep going. You know, everything that's been mentioned today, you know, patient advocacy, being more involved, having options, you know, globally as well as locally. We have to keep forging those forward. All of us that work in clinical trials take those patient messages and get over those hurdles, work away around these things so that there is more equity of access for patients, and they get it when they need it, not, you know, 6 months later while we're waiting to set up a trial or something, that it's available as they need it.
Yeah.
It's very important.
Well, thank you again. And we've only 5 minutes over time, so we've done very well. Yeah, we've done good.
Well done to all of you.
Yeah, thank you so much.
And good luck
Thank
with
you
your
so
journeys.
much.
A recording of the video will be made available. Fiona will email everyone when that's up and live on our website. So for anyone that missed it, or anyone who wants to look back on any of the stories shared today, that will be possible. Happy International Clinical Trials.
Thank you.
Thank
Great.
you.